Well, hey there, it's Liz Rohr from Real World NP, and you're watching NP Practice Made Simple, the weekly videos to help save you time, frustration, and help you learn faster so you can take the best care of your patients. So, in this week's video, I'm going to be talking about a type of visit that really scared me as a new nurse practitioner, and that is newborn visits. So, that day 3 to 5, first initial visit after discharge from the hospital. I have to be really honest, I still find them a little bit intimidating. But in this video, I'm going to go through the kind of step-by-step that I follow every time and that I recommend you do as well. So one of the super helpful things if you have a baby who is discharged from the hospital setting, usually they either bring some sort of discharge information with you, or like your hospital system will be able to have electronic access to the discharge records, where the neonatologist, the provider that assesses them after birth, gives a really detailed rundown of their physical exam and all the things that happened there. So usually I start by, I think it's really hard not to get sucked right into all the details of the visit, but I really try to start by mothering the mother. I mean, there are many different kinds of families that come in with newborn babies, and not necessarily like a cis female, but typically that's who I see in primary care. Whoever your parent is, mothering the parent, because for them, this is a really overwhelming, typically experience, and just checking in with them first before you dig into all of the kind of assessment details to make sure that you've gotten all your ducks in a row. This is certainly easier if you've had your own child before, but I did not when I was a brand new grad. So once I checked in and see how the family is doing, whoever the family is there, I kind of see how it went for them, how they're feeling now. A lot of times birth can be pretty traumatic for a family member and the person who's delivering the baby. So it's really important to check in with that. It's helpful if you have a rapport with them in the first place, but at the very least, if you've asked once, you can kind of, or multiple times in the first visit, rather, the first time meeting them, it opens the door that if they don't fully disclose their experience that time, they can kind of continue on with that. So kind of after getting to know them, where they live, who they live with, what support they have at home, if it's their first child or not, those are really helpful contextual pieces of information. Our clinic also has a standardized procedure where we ask patients about social determinants of health and if they have any issues with housing, with meals, like things like that, and that can kind of help fill in those further contextual details. So as I'm talking about this, I acknowledge that our visits are pretty short. Mine are about 15 minutes, and I have to be honest, most of the time I go over because it's a lot to talk about in this visit, and I hope that you actually get a little bit more time, closer to the 20 or 30 minute mark. But anyway, once you've checked in with the family, you can look at your hospital records and see, what is, usually there's a detailed birth history document. In my EHR, it doesn't let you chart without it. And so I'm usually starting with their date of birth, their time of birth, which is really important when it relates to jaundice. If they have jaundice. The first thing to start with, if hopefully you have those hospital records in front of you, and if you don't, just try your very best to get the information from the parents that are there or the family members that are there. But the first thing you want to think about is kind of the history of the delivery and also the prenatal care. Did mom have, again, I'm saying mom because it's usually a mom that's there with their newborn that is just delivered. Did they have prenatal care? And did they have any infections or medical conditions during their pregnancy, like gestational diabetes or other things like that? Did they take any medications during pregnancy? And then when it comes to the actual delivery, did they have a vaginal birth? Did they have a cesarean, emergent, scheduled? Did they have any assistive delivery devices in the delivery with the vaginal birth, either forceps or suction? Were they induced? That's all important information. What was the estimated due date and the date at time of delivery? Were they 40 weeks? Was the baby 40 weeks, 39? Term baby, preterm, like that kind of thing? Did the baby have any fetal distress, any NICU stays, anything like that? Were any complications during the delivery, including like a fever during the delivery from the mom? And so after you've kind of gotten your like labor history, how long the labor was, prolonged rupture of membranes, I'm trying not to go too big into this video, but those are the general highlights. If you're touching on that topic, you can kind of consult and work through your brain of what you already learned and also what you have other resources there to put all those pieces together. So again, just kind of like recapping, there's a lot of stuff, right? Checking in with the family. How are you doing? Do you have records? What was the prenatal care? What was the delivery like? And then what day of birth are we at right now? And one of the kind of main orienting things that is really helpful, really with all pediatrics, but especially with newborn babies or babies of any age, is kind of these orienting questions, right? Eating, eating, elimination, sleep, behavior, alertness, other kind of like ROS general symptoms, nausea, vomiting, diarrhea, that whole stuff. Well, not really for babies, right? But anyway, so checking in with those kind of main pillars of pediatric wellness, right? How much are they eating? And are they breastfeeding or formula feeding or both? Because a lot of people do both. What are their desires, right? Are they hoping to breastfeed? Are they having a hard time? Did they meet with anybody yet? I could get into a whole different video about breastfeeding and that whole thing. I'll leave it at that, but kind of checking in to see how that's going for them, how often the baby is eating. And then the next question, usually typically about that time, it should be about every 1 to 2 hours, every time they cry, on demand. And then usually in the first couple of days to like the first week, they really should be eating about every 1 to 2 hours with like a stretch of 3 hours. It's really hard for the families to do that, but that's usually what the babies need because their tummies are so small when they're first born. So checking in with their nutritional kind of intake. Elimination is the next question. So how many diapers a day? And usually by the time you're seeing them, it's day 3 or 4 of life. And at that time, between day 3 to 4, they should have about 6 to 8 wet diapers in a 24-hour period. And they should be stooling by day 2. And an important question is, in addition to how many wet diapers, how many stooling diapers, and it can be as often as every time they eat or infrequently as every couple of days. At this point, though, you want to have seen some stool, and you actually want to also document the color too, which is kind of like a weird, gross question, right? But you're trying to assess, has it changed from meconium to like either breast milk stool or formula stool? The next thing is about sleep. And you know, it's a difficult topic. And again, this is easier if you have your own children or if you've had a child before or cared for a child before, especially a newborn baby. But sleep is typically they're awake all night because they're like in utero, they're used to the mother being the parent being asleep during the night and then lulled to sleep with their movements during the day. So anyway, that can be a difficult transition and that's completely normal. So that's a lot of reassurance for them. And again, they really only have like a 3 hours window of time where they sleep like one time in 24 hours for the parents to kind of catch up because they need to eat so often. Because the risk there is dehydration. You don't necessarily want to scare the parents by talking about that, but just kind of like getting a sense and trying to be at ease yourself when talking about it helps to kind of ease their mind. And after talking about that, you want to kind of, again, going back to your making sure that you have that full history. What were their vaccines when they were born? Did they get hepatitis B? Did they get vitamin K? All of that kind of general history stuff. And I don't want to get too much into that because I don't want this to be like a million years long, but looking at all of those kind of checkpoints. And usually your electronic health record can be really helpful because it will prompt you for all of those questions. And then you'll say, oh, okay, I'm going to go find all of those things. You know, the maternal blood test, the baby's blood test, like et cetera, et cetera. A couple of other screening things to keep in mind. All babies will, born in a hospital setting, will have a hearing screen. They will have their newborn screening labs, and then they will also have screening for heart disease, like congenital heart disease, using the oxygen monitoring. And if they pass, there's like preductal and postductal. It just has to do with like where they measure it on the body. I think it's like hand and foot. And then the other thing is jaundice. So there is some sort of jaundice, bilirubin screening for jaundice. And I'm actually going to make a separate video about that because I see this all the time. And the newborn visit by itself is stressful, but then you add jaundice on top of it can be a little bit intense. So I'll make a separate video about that, but I'll be talking about jaundice there. But there's definitely a bilirubin screening. So yeah, and aside from that, it's your general kind of physical exam. And this is very basic, right? This is a basic orientation because whenever there's an abnormality, you just have to go down that path, right? Is there is there a hematoma in the back of their head, right? Is there some sort of congenital abnormality that they've come out with, right? And typically the nice thing when you get that is that usually they've already assessed it and they've kind of come up with a recommendation. So for example, I had a baby with hydronephrosis, detected on the in utero ultrasound. And so they already knew at the time of birth that this was an issue, and they already had a scheduled appointment with the nephrologist to follow up. And they kind of told me exactly what to do, right? And a baby who was born breech, and they said, you know what, needs a follow-up ultrasound in 4 to 6 weeks. So a lot of the times, if you can get those hospital records, they're really helpful. But like I said, every single time there's an abnormality outside of the window of expected is really just taking that path and researching it down and just making sure that you're doing your due diligence, working that up, and asking all the questions of your supporting providers, because it's normal to feel a little uncomfortable with the newborn babies. Even pediatric NPs do, pediatricians do. It's just, you don't want to miss anything. So there's no harm in asking questions. Those are the general kind of things to think about when you're doing your assessment. And then you want to think about their birth weight, their discharge weight, and what's their current weight. And as you remember, they're going to lose about 10% of their body weight, which they will regain it at 2 weeks in. But you want to kind of see like how much have they lost so far. And kind of just looking at that, doing their physical assessment, like how do they look? Do they have any abnormalities? Do they have any signs of like dehydration? Do they have any jaundice? Can you get a red reflex? That's really hard to see, but you got to give it your best shot and just keep trying and you'll find it, I promise. So after you've done your history taking and assessing where they're at in terms of the elimination, the intake, all of that stuff, how they're sleeping, how the feeding is going, the next kind of piece, and aside from the physical exam, again, branching off depending on the abnormalities that you find, because I can't talk about every single one that you could possibly find, because again, this would be like years of conversation. But just like kind of like reading into those cues of like, okay, if this, then this, and the next thing is about anticipatory guidance. And there's a lot to know here, especially again, if you haven't had your own children, like there's a lot to think about. But like I kind of start with just like, what are the most important things, keeping in mind that they are likely very sleep deprived, overwhelmed, and just like exhausted. So I usually keep it to like the most important things, like do not miss these things between now and your next visit. So always saying arm's distance away. So I see a lot of new families where they will be away from the baby, and the baby will be on the exam table, and it's a newborn baby. It's probably not going to go anywhere, right? But like some of them are very strong. And so I always say, arm's distance away, always within reach of the newborn. Whenever your back is turned, always have a hands on them or near them. The other one is about body temperature, right? Because they are born with the brown fat. And so they need to make sure that they are warm enough. And so one of the rules of thumb is kind of like, if you think about your own body temperature, the clothing that you would wear at this temperature in the room, like add like one more layer, just being mindful that you can overheat them and you can't overbundle them. And they might not necessarily be able to kind of communicate that, right? Because they're new babies, and they might not necessarily be able to modulate that either. So the other thing is like people ask about the ideal room temperature, and like there isn't really one, but like 68 to 72, maybe some baby books say. The other thing is about fever, monitoring for fever, right? So anything that is greater than 100.4 needs to be urgently, emergently dealt with. And so making sure that they have the on-call number for the clinic, or knowing where to go to the nearest ER if they need to. And then just, again, being aware that if you overbundle them in the summertime and they feel warm, unbundle them for a little bit, like for like a little while, not making them cold, but making sure that it's not falsely high because they're super bundled up. And then the next stuff is just reinforcement of all of the feeding. Like what are the things they need right now? They need safety, they need to eat, and they need caring for, right? So I'm making sure that they feel comfortable with whichever feeding option they've chosen, whether it's breastfeeding, formula feeding, or both. And breastfeeding, we could get, that's like, again, a whole nother topic. And if you're interested in hearing about that, I'm happy to talk about that. And actually I have a really wonderful colleague who is she's a physician, but she's also a lactation consultant, and she's pretty wonderful. So I'm happy to ask her if she's willing to come on. I don't know if she will be, she might be too shy, but I can always ask your questions if you have them. But yeah, and then in terms of the when to follow up, depends on what's happening, right? Depends if they have jaundice, depends how well they're eating, depends if they have any things you've detected or any concerns or how concerned the parents are. But I'll definitely do a check in about a week to see how their weight is, right? Depending on how they've gained since birth, and depending on how it's going with the wet diapers and all that stuff. That's not a very like straightforward answer. And I know that you appreciate straightforward answers, but if you want one, check in 1 week, right? Keep checking babies in a week later or sooner if you have concerns, right? Unfortunately, there's no real blanket statements here, but it's just kind of using caution, using your clinical judgment, and yeah, so hopefully that is helpful. If you are interested in the kind of like cheat sheet that I have that goes along with the newborn visit, it's actually in the digital NP binder, which is all of the cheat sheets I've ever made, plus additional bonus ones, including the one from today. And you can purchase that down below this video, and it's pretty wonderful. And it's also updated every 3 months. So with brand new stuff. So yeah, so thank you so very much for watching. Stay tuned for next week's video, which is all about newborn jaundice. And hopefully that one is also very helpful. Please let me know what questions you have. Thank you so much for watching. Hang in there, and I'll see you soon.